Good morning. I'm Cholwani from Mass America Center. Welcome to TCTAP 2015. Now, I would like to start the symposium by live transmission from Columbia University Medical Center. For these sessions, I would like to invite Dr. Mintz, Dr. Seung-Jung, Dr. Stone as moderators, Dr. Grube, Dr. King, Dr. Rutherford, Dr. Kim, Dr. Tsuchikane, Dr. Waksman, Dr. Yamane, Dr. Yeung as discussant. Would you please come up to the stage? I think this Columbia team is ready.
안녕하세요. 좋은 아침입니다. 저는 제주 한라병원 심장내과에서 근무하고 있는 김성식입니다. 콜롬비아 대학병원에 오신 것을 환영합니다. 이곳에서는 언제나 놀라운 일이 일어나고 있습니다.
Thank you so much. Good morning, everyone. It's Tamim Nazif from Columbia. We have a great case and a great team here for you today. I'll introduce the team first. To my left, Dr. Dimitrios Karmpaliotis, Martin Leon, as well, Jeff Moses. We have on IVUS, Dr. Kadi Fall, helping as well, our angioplasty specialist, Mark, and our nurse team, including Dennis, Tina, and everyone else. We'll present the case then, if I can have the slides, please. Okay, so our patient is a wonderful 59-year-old man with history of non-Hodgkin's lymphoma, status post-mantle radiation in the 1990s, with resultant pulmonary fibrosis, aortic stenosis, status post-transcatheter aortic valve replacement, CAD, and cardiomyopathy. He has a CTO known from the time of his TAVR in the mid-LAD, presented with dyspnea on exertion, and has nuclear stress as well as MRI, evidence of anterior ischemia, as well as viability. The other medical history includes hypertension, dyslipidemia, the non-Hodgkin's lymphoma, pulmonary fibrosis, and CKD with a baseline creatinine around 1.4. Next slide, please. The patient initially presented to us in January of last year with cardiogenic shock, respiratory failure, and renal failure requiring dialysis. At that time, he was found to have severe aortic stenosis, the CTO of the left anterior descending artery, and a cardiomyopathy with a left ventricular ejection fraction of 20%. He was treated with balloon aortic valvuloplasty, followed by a staged transcatheter aortic valve replacement with a Sapien XT valve. He stabilized clinically, and there was improvement in the left ventricular systolic function to an ejection fraction of 40%. Now again presenting with dyspnea as well as SPECT and MRI evidence of ischemia and viability. Next study, please. The echocardiogram shows normally functioning bioprosthetic aortic valve with trace aortic insufficiency, preserved LV systolic function with an EF of 40%. The MRI shows anterior wall hypokinesis with small subendocardial infarction and viability extensively in the anterior wall. Cardiac catheterization was performed. We'll show first the angiogram from a year ago. Can we go to Accelera, please? Okay, and I'll turn it over here to Dimitri.
Hello, everybody. Welcome to Columbia Cath Lab. We see here an RAO shot from about a year ago. The patient was very sick, tachycardic. You see a swan in place. And you see that his left main has no significant disease, left circumflex mainly a big OM1, no significant disease, and there's an occlusion of the mid-LAD. Next slide, please. Here in the cranny shot, you see that there is occlusion of the LAD after the takeoff of a big septal that gives multiple branches, and then there is left-to-left collateralization probably through the septum. You also see that there is a relatively large diagonal branch that is filling via epicardial collaterals from the left circumflex system. And at this film, it's unclear whether they are true occlusions or whether they're connecting at the distal cap. Next film, please.
You want to show this now?
And this is the contralateral injection from the right coronary artery. You see there's no significant disease. You can see that there is some ghosting of the LAD, probably filling via epicardial collaterals from the surface of the RV. The first part of the LAD that is filling is the mid-LAD, and that's the angiogram about a year ago.
So this is before the valve went in, so he's tachycardic, in shock. He's got an occluded LAD with an EF at 20% before you did the BAV and stage TAVR.
So his clinical presentation improved dramatically, and he's been doing well except for residual dyspnea on exertion and significant ischemia by MRI. And here you can see...
Show the angiogram
Can you show the
please?
angiogram from today, please? So you see the sapien valve in place, and you see an 8 French guide, and it looks a little bit better than it looked a year ago. It still fills probably via collaterals first, septals, but clearly there seems that there has been some form of recanalization. And then I'll show you the dual injections here. First from the right, there are still some collaterals from the right. And here you see the beauty of the dual injection. Essentially, it's a very short, if at all, functional CTO at the distal cap of the mid-LAD with a significant diagonal.
Dimitri, how much of this change, if you will, do you think is related to improved hemodynamics?
This is a very interesting question, Gary, and actually that's what we were just discussing before we went live. I think that it's probably, once his hemodynamics improved, I think that probably helped with recanalization, better perfusion pressure, and obviously less diastolic dysfunction, so I think, and lower EDP, so I think it clearly helped.
Sure. So I think clearly by fixing his aortic valve, improving his ejection fraction, I think you've increased the antegrade perfusion pressure, and that's helped with this recanalization. It's still filling distal before proximal. It's still, I think, by strict definition is a CTO, but it's a short CTO, and there's a large diagonal branch, and it looks like there's disease that extends both into the LAD and the diagonal branch. So it's going to be a short CTO bifurcation as opposed to a more complex, longer CTO.
Maybe the DAP helped also in the valve.
Could be.
But we can always make it complex.
Yeah.
Yeah, so
It's
good.
a endeavor not to do that. One interesting thing shown also in this angiogram is one interesting thing is the sapien XT valve in relation to the coronary os. You see that the left coronary os is significantly above the top edge of the frame. The right actually was also surprisingly easily accessed. And it's potentially one of the benefits of the sapien valve family, the relatively short stent height preserving access, and it was one of the things taken into account in the choice of valve for this patient.
You used the CT to predict this?
Indeed.
So Dimitri, Marty, good morning. We've got some true CTO experts here, including Etsuo Tsuchikane and Masahisa Yamane. So this certainly has gotten much easier over the last year, so sometimes there is a benefit to waiting. But I might ask Professor Tsuchikane Sensei what your approach would be.
Yeah, of course, fortunately today partially recanalized, so that antegrade approach is maybe good enough. But because of a poor airway function, one issue is how to preserve a diagonal branch at the distal bifurcation.
So right now you can see some calcium there. The vessel looks very small and diffusely diseased. Of course, it's going to get much larger once you're able to cross it. So Dimitri, your approach is to take well, tell us what your approach is. Given that there might be a microchannel here, what wire do you start with?
Yeah. Actually, what does the panel think? What would they pick? We had a little discussion about it. What's the wire of choice for these?
Okay, so who on the panel might start with the Gaia series of wires? Anybody? What about a Fielder XT? Fielder XT, I'm seeing some yeses. Looks like Fielder XT is the near unanimous choice.
We can't see the hands going up, Greg.
I know. Some people put up two hands.
Okay. Okay.
So you taking a fine
Yeah,
cross or a
we're using the
Corsair?
Gaia 1 in place of that pretty routinely.
Yeah.
We are taking a short Corsair. We took a workhorse wire just to get us into the area of the lesion. And lately what we've been doing as the first wire of probing just for a few seconds as CTO instead of the Fielder XT has been actually the Xion. So we decided after a lot of democratic processing and voting going on here that we're going to start with the regular Xion. If we have any issues, then we should switch to a Gaia 1. For some reason, we have not been using the Fielder XT as our first wire lately. So, Jeff?
I think the Gaia has a little better body. It tracks beautifully, and if you keep your eye on it so it doesn't go subintimal, I just think it's just an easier wire to navigate and manipulate.
But why Xion over XT? What is the reasons for that?
Well, the Xion and the Gaia will give you, especially the Gaia, will give you more feel.
No, Gaia I understand it, but as a second wire, because again, it can be, you have to be very careful with the Gaia. But why not XT as a first choice? There is not really much reason for that. Yeah.
Okay. Well, that's interesting, because the panel is pretty still unanimous for the XT.
Okay, I'll take a Gaia 1, please.
All right. Well,
you don't give much chance to that now.
We're at a step.
Yeah, so I think you certainly want to be careful that you don't just say.
Take too long.
30 seconds. If it doesn't,
right.
Yeah. And also, you see the wire getting stressed. It doesn't have the body to make it through the occlusion.
And the Gaia has a freeform tip already too.
Yeah, better tools.
So the Gaia first will not have too much more body than this.
And the Gaia has a freeform tip already in the US.
No, but it may, it's tapered, so, it may find, the microchannel, if that's what we believe it's there, with a little bit more easy than the Xion or the XT. So this is a Gaia 1.
The Gaia series of wires is relatively new. I'm certain that many of the people on the panel and on the audience probably don't have that much experience with the Gaia because, we're just beginning to understand how to best use it.
Like sort of that way.
It has a very good trackability, but it's risky for perforation, so you have to move very, very slowly with that wire.
Well, it's really got unsurpassed torque control.
Even the Gaia 1, you think, is risky?
No, not 1.
The Gaia 1 is a fairly floppy wire.
But usually if you start the XT and then move to Gaia, you probably would move to Gaia 2.
Mm-hmm.
No, look, we've only had these for about 5 or 6 months.
Yeah.
And we're still experimenting with our order.
So this comes pre-shaped, Dimitri? Did you just accept the shape?
It's come pre-shaped, yeah.
That's a good 1 millimeter tip.
Yes, correct.
Yeah. It's actually pretty important. I think the way it stacks up and the coils align internally and externally, I think if you put an excess of bend on it, you lose a lot of its force.
Right.
So if there was a question of whether this is a CTO, it behaves exactly like CTO.
I think it looks like you're going somewhere.
This is a CTO. It looks like you're heading towards a diagonal.
It behaves like CTO.
So it's interesting that compared to the Xion, you can see that the inner core of this wire keeps the integrity of the wire. It's not buckling the way the Xion did.
Yep.
And I think that helps you. I mean,
I'm
you can
also
really
much more,
torque this.
careful with.
You can really torque this wire even inside plaque, but.
Let's do a retrograde picture.
So that's. Yeah. Not sure where you are. You're moving, but.
You're making progress somewhere. It looks like it's a.
It's probably false lumen diagonal.
I don't like it.
Yeah.
Yeah. I think you're in a false lumen.
This wire is not in. Yep. Okay. Let's get a Gaia 2, please.
While you're working out the technical details, Dimitri, let me
we'll
just ask. So the big trouble was the aortic valve originally. It had this dramatic improvement in LV function. So what it teaches me is that next time I see a CTO, I'll do TAVR on it. Yeah. But in addition to that, these current, just so we can remember the current situation, I forgot, there's ischemia, I agree, definitely in the anterior wall. I know that because there's no blood going there. But what was the objective measurement of that anterior wall ischemia? Did you mention that there was
Tamim?
Some, there was a scan?
Yeah, there was a SPECT nuclear imaging and followed by an MRI as well.
And did that translate into the patient feeling bad or anything like that?
Honestly, I think with viable wall and symptoms, I think you could make your case.
The symptoms were significant. Okay.
He still has a residual dystonia exertion, which could be multifactorial. Can I have a torquer, please? So but he still has a low EF of 45%. It's hypokinetic and it's fully viable. He's a relatively young guy, so I think that it's defensible to go ahead and open up the.
If you have an opportunity to improve LV function, especially in someone younger, given the prognostic benefit of another 10 points in EF, I think it's worth your while.
Right. I completely agree. Just wanted to see.
So, Dimitri, when you are getting into the false lumen, what makes you decide to keep the wire there and use a second one versus pulling back and try another one and get into the right lumen?
That's a good question. Eberhard, is that you?
Yes, it's me.
Yeah, so I almost never perform a parallel wire. So what I'm doing here is just trying to deflect from the subintimal space and try to find the path of least resistance and try and torque and stay centrally by going back and forth. If this is unachievable, then I will have to very quickly change my strategy either to a dissection re-entry or to some form of retrograde approach.
I see. And are you using routinely?
The way we've been doing the CTOs.
Are you routinely using an 8 French?
We've walked away from parallel wire. Yes, for the most part, yes.
Okay. Now, I haven't seen much collaterals from the right.
Eberhard, we've been playing with combinations of radials and femorals and somewhat smaller guides, but in a case like this, we generally would use long sheets, double 8 French guides, good support on both sides,
like
with an en-plots on the right and with a broad transition left.
Pilot thing, or should I try the Finger XT for a second?
Try an XT.
It's interesting. We thought this was going to be easy to recanalize. It's not behaving so easy.
So now we're going to see how smart the panel is. We're going with the XT. But of course you'll say we disrupted the plaque.
Well, that's right.
So
of course you've already disrupted our plaque. So, you may have left earlier. You may have left earlier than you think. It's diffusely diseased. There's probably a lot of calcium in the course of this vessel. So, as we know, the length is really no longer predictive about success or failure with current techniques. But you can see the calcium right after that diagonal.
But given the fact that you were there with Gaia, it maybe requires some stronger wire to break the cap.
Yes.
And whereas the curved tip is, enables you to do all the direction, I'm just wondering, Dimitri, it seems like a straight shot. Is there any rationale for taking a straight wire and just trying to, without a curve, and see where it goes?
Just dottering.
Or the classic Confianza Pro with a 10-degree bend.
I wouldn't do that. I wouldn't do a completely straight.
But you know, a 10, 20-degree bend with a Confianza Pro may be not unreasonable here. So there, I think you're in the false lumen you created before.
So this is the Fielder XT.
Yeah, when it's moving to the false lumen faster.
Yeah, but it's going in.
Yeah.
So see, Jeff, you did disrupt the vessel.
Yeah, that's a false lumen.
Yeah, you see?
Yes, we managed to do that.
Yeah, I mean, that's the subtlety of the Gaia. I mean, supposedly, if you don't see deflection, it's supposed to be in the plaque and not going subintimal, but that hasn't entirely been true.
Yeah.
I think the entry is much...
Yeah, I think it's more proximal, actually.
It's right in the crotch.
Yes.
It takes it takes a south bend right around,
way back there,
right after the occlusion. I think that's the issue.
So, I mean, the hope with this wire was just really to find a microchannel, but if you're really heavily calcified, it's not going to do it.
Yeah.
Well, microchannels are now out of favor, right? It's like loose tissue, right? It's the buzzword now.
Yeah, it does go to the
same thing.
step intimate.
Okay. Should we do...
So what Eberhard would have done, he would have left the wire there and come with another wire.
Try a stiffer
You
wire.
want to try a pilot first?
A parallel wire would not be bad here. I mean, you know, you've got a nice marker for where that diagonal false lumen is.
Give me a pilot 100, please. Huh? Pull it. Give me a pilot 100.
I can't remember the last time I've seen Dimitri use parallel wires.
Something about the Greek Orthodox. They just don't do it.
You can call me stubborn, but it's hard to talk with.
Dimitri, sorry to...
I don't want to confess that. This isn't the worst. That's not the worst idea.
Maybe out higher up. You can maybe exiting sooner.
Yeah, the entry is higher.
Yeah.
Dimitri, is there any role for a miracle in this situation?
Yes, I think there is. It might, cut some tissue away from the flap that we created, and it might be helpful.
And since all the wires so far till now have been tapered, it may be the 14 may track a little better into the true.
Yeah, I mean, with the diffusely disease calcified vessel, you sometimes need a wire with body.
Well, I must say many of the hybrid aficionados don't use miracle wires very much.
Yeah.
They would go straight to a Confianza.
Well, what were you saying about?
So what's the next wire? Is that a pilot?
I think it exits higher.
Yeah.
It exits
Yes, it's a pilot.
I think higher up.
This is a Pilot 200.
Sort of the wire we want to take care of us.
Yes, I'll take a torque.
So it was a little hard for us to see. Was there much of a retrograde option?
Yeah, we didn't see many collaterals there.
Test this.
Yeah, because there's enough left to left.
So there's retrograde septal to septal, possibly. And there's probably something you can find off the right. But it's not immediately obvious. I agree.
Going into that.
Yeah.
So, Professor Tsuchikane, how long is it going to take you to convert from antegrade to retrograde?
But in this case, there is no good interventional collateral, only ipsilateral septal connection, so that we should more focus on the antegrade model.
Well, we might, with the diag there, we may surf it as opposed to ADR, don't you think?
Yeah, I think we're wasting our time here with a...
Yeah, if you could get in the architecture of the vessel, it's relatively straight. For an antegrade dissection re-entry, but...
Yeah, I'm just concerned about that losing that diag. We'd really like to preserve that, Greg.
Yep.
And I don't know if there's much of a landing zone. You'd literally have to hit it right at the bifurcation. So what's that?
That's a little more interesting.
That looks a little more promising.
Yes.
Okay.
see.
We'll see.
Let's
Is that
let's see.
accepted?
We'll see.
So this is the Pilot 200 again.
This looks like promising.
It looks like it might be in. Let's take it.
Let's do a duel.
Not seeing anything.
I think you're maybe okay. Well, we'll see in a minute.
Yes.
There you go. Great.
Very good.
Fantastic.
You're right, Jeff.
So I think you re-entered. I think you went out and re-entered.
Yep.
So
So
when I'm
Ibis-
desperate,
Ibis
when
will
I'm
be interested.
desperate, what I do, I just ask for a pilot. I close my eyes, I spin, and it finds
It
the
takes
way.
care of us, or dissects, in which case we do an ADR. It's a very simple, it's compressing the entire algorithm into one line.
So what's going to be interesting now is we're obviously going to exchange for a safer wire, and then we need to decide and hear your opinions. Would we go to balloon the LAD and then go for the diag, or try to IVUS first and see where, because it's a good chance that we were in and out, subintimal, and then the pilot found its way in. Or people would try to primarily wire the diag at this point?
Yeah, it's nice to see
So
the
Dimitrios
Corsair
working down with the
crossing the
Corsair
lesion.
over this Pilot 200.
So the
I
Corsair.
would IVUS to see what the dissection is, Dimitri.
Okay.
And then you maybe feel safe ballooning it if you know the origin is open.
I'm okay with that.
I think that's very reasonable. I think it's going to be very hard to directly access
any
that
idea from the
diagonal.
Shorter balloon.
I probably would tend to use a small balloon, a 1.5 balloon. Any other feelings? I think it's going to be very
agree.
hard to wire that
Pre-dilating.
diagonal.
Yeah, well, yes, well, 1.5
or a
balloon.
2.0 balloon long.
Yeah.
Even a
and
2.0.
And then IVUS.
And then IVUS.
Yes,
So every-
give me the longest 2.0 balloon.
No,
that
I
you have.
agree. I don't want to do aggressive.
Pretty much
Just
the
enough to get
panel is
IVUS.
agreeing
Yeah.
to.
You know, sometimes you'll open up the entry to the branch, which will make
Right.
wiring the branch much easier.
That's the panel is saying go ahead and balloon it with a small 1.5 or 2.0 balloon.
Yeah.
Yes.
Yeah.
2.0, yes.
We absolutely agree with the panel. Even this panel agrees.
Your panel's almost bigger than our
my
panel.
principle to agree with the panel.
Which panel do you want to agree with?
You got 10 versus 5. I think.
Yeah, we'd have 10 also, Greg, but some people had to go to dinner.
Greg, if I may make a comment that we've been discussing for a while now, you know, we don't do distal tip injections.
Right.
And we take a workhorse wire, a coil wire, and then we just exit very, very slowly. And, you know, we select branches, and that's one sign that we are in the true lumen. The other is that it's moving. If it was subintimal, it would just crunch and wouldn't go. That's a pro water.
It's a pro water.
Yeah, anyone like the Pro Water or the Universal, if it's subintimal, will crumple up.
And I'll take a 3.0 balloon for
You know
travel.
that very soon.
All right, so we're going to trap this with a 3.0 balloon. We're going to take a 2.0 long balloon and do some gentle dilatation through the CTO and see what happens.
Yes, and we crossed for our database at 0.46 gray, 14.5 minutes of fluoro, and you gave them the contrast? What was like 80 or something? Okay.
So you just needed a wire with more body.
110, 120 of contrast.
I mean, in addition to the hydrophilic component, you needed something
Yeah,
with more control, more body for that because of the calcium.
Yeah.
Yes.
Honestly, the Miracle 6 might have done the same thing.
Yes, absolutely.
It might have, Confianza Pro might have done the same thing.
Yeah.
Yes. The only comment I would make about choosing the pilot, although it kind of sounded counterintuitive, I already had a dissection plane. You put a jagged wire with a high ground force. It's a very safe wire in the body of the occlusion. It's almost unheard of to perforate through the adventitia at the body of the occlusion. It's very dangerous further down, and that's why we change it. Come down the top left.
And remember, the subintimal track you made was like a 0.9 or 1
Yes,
and that was a 14 tip. So that may have directed you.
So that's the reason why La Confianza, you know, can play you tricks sometimes. That's the reason for the pilot. I think it loves to stay in the architecture of the vessel, and with a small bend, sometimes it finds its way into the true lumen.
The IVUS will be interesting, though.
These bifurcation curved LEDs, I find the Confianza always ends up right in the middle of the two branches.
Yeah, the IVUS will be interesting because I suspect you might have exited and re-entered.
So, Dimitrios, you prefer the Pilot 200 over the Confianza?
I'm sorry, come again?
You prefer the Pilot 200 over the Confianza in a situation like that?
It obviously depends upon the situation, but I would say that in my escalation algorithm, go up please, go up. In the escalation algorithm, I would probably reach for a Pilot 200 first before I go to Confianza in the vast majority of cases.
Yep. 6, 8.
Down, unless I have a very, very specific, 2-3 millimeters of a very calcified like a rock area that I want to penetrate. I don't run the Confianza any more than a few millimeters up or down the vessel. Let's give a very gentle...
Yeah, the likelihood of dissecting with that sharp tip is
I think the other thing you'll notice is we don't like to give much in the way of contrast. Antegrade, we're very careful about, this whole issue of hydraulic dissection, so...
Yep.
Okay, I think that the ibis will go now. So what does the panel bet on? That was all the way into the plaque because there's no really true lumen in a CTO, or was I in and out? Gregg, you vote for in and out?
I'm voting for in and out. Gary, what do you think?
Yeah, probably in and out, but I think it's pretty short.
Yeah, it's short. It's only going to be a few millimeters.
Yeah, but I think the most important question is there any dissection in front of the diagram?
Exactly.
Yeah, the other question is really less important.
Yeah, because if it's very short, but it chops off the diag, then it becomes important, right?
Yeah, exactly. Then you're doing a ADR.
Can we have the ibis?
We still may use the stingray, the diag.
Yep.
All right.
Can you have them increase the gain just a little? Dimitri, ask them to increase the gain just a little bit. It's not.
Can you increase the gain a little bit for Gary?
Thanks.
This is Mike.
That's better.
So obviously we're intraluminal here.
Weak eyes, Gary? Is that it?
Yeah, that's fine.
Coming up, almost coming to diag.
Yeah, it looks true there.
No.
Here. No, there was a delay, Gary, in my...
Yeah, it was hard to see the media all the way around, Gary.
I agree with Gregg.
I think you were in the false lumen, Dimitri, where you said it was true.
Yeah.
Now you see the media all the way around. Now you're in the true lumen.
No, there's a delay in transmission.
That could be.
But
delay in translation
Audio.
or delay in transmission?
So where's the diag? You see the diag?
Here's the diag,
No.
No. It's a wire.
I'm not sure. I don't think
we passed the diag a while ago.
Yeah, I don't think we see the diag.
No, we have not seen the diag.
I would bet that the diag was in that area of a lot of calcification that we passed.
Exactly.
I agree, Gary. I think you didn't see it because it was shadowed.
Yeah, can we go back on that then?
Okay, that's good enough there. We can stop and then you can play it back, see if we can identify where the diag is. And give me a 2.5 by 30 balloon. I'm going to dilate it a little bit more. And then if the diag is
so you may actually
shut down
be,
by a flap, we'll figure out a way to deal with it.
You may be in the false lumen for longer than we thought.
I agree with Gregg. And I think the diagonal's coming in at 12 o'clock.
Could be.
So at the beginning of the pullback, you definitely were in the true lumen, but then you relatively quickly went into a false lumen.
It's the false lumen.
Yeah, I totally agree, Gregg.
The question is if you can salvage the diagonal before you balloon or do any more dilatation there.
See, that's just adventitia at 12 to 6 o'clock. There's no, now there's media. See the difference from media?
Yes.
That's media. A few millimeters distal is not.
There's delay, so we can...
Yeah.
No, we agree. It's short, but maybe in the wrong spot.
2.530.
And again, I agree, it's hard to see that diagonal.
So it might be important to tell us what this information is going to do in terms of changing your,
I think it's
how you proceed.
It's in the beyond the adventitia. We're subintimal.
Yeah, but how is this changing how you proceed? This knowledge of that you're subintimal. How is that going to change the?
When this case, I don't think it helped a lot because you really couldn't see the
probably
diagonal.
That we're going to have to independently access the diag.
We're hoping to see a
maybe
different.
do a dissectionary entry.
Hoping to see a different picture, Spencer.
It depends what we see now.
I think part of
this is a 2.5 balloon to about 10 atmospheres.
Spencer, I think the one surprising thing was how far down the false lumen extends.
Yeah,
that I think
exactly.
Is probably the
that surprised me also.
Down.
So this might move you to select a longer stent than you would have selected
absolutely.
otherwise?
Absolutely.
Oh, yeah.
Yes, yes. But again, to me, 5 or 10 millimeters of stent, I don't think it's a big price to pay as opposed, to going epicardial polar. The key thing is the diagonal. So that's going to be, I think, more important than a little bit longer stent.
So would you consider to wire first the diagonal before you put the stent?
What's the last ACT?
Dimitri, do you ever have an angiogram?
We're going to take a little picture now. We'll see what it looks like. And
we're obsessing about the diagonal. Do you have an angiogram from years ago when that artery was open? Do you know how big a diagonal it actually is?
Clear it. It's actually, it's probably sizable, judging by the length of it and the territory that it covers. Okay, ready? Okay.
To answer your question, Greg, he was not studied previous to his presentation for the TAVR.
So you kind of see a little stump here where it takes off, but...
I mean, Dimitri, the other thing is we always say that you need to end the stent in a true lumen.
Options are an epicardial entry.
Mm-hmm. Yes.
So I think the length of the stent in this situation is
very difficult to.
Is important only in the sense that you want the distal end of the stent in the true lumen, and whether it's an extra 5 or 10 or 15 millimeters is irrelevant because you need to get into the true distal vessel so you have outflow.
Correct.
Yeah.
Correct.
Yeah, we're not so worried, Gary, about the LAD. I think we should be able to stent it, true to true. I think the issue is we're really having trouble identifying the entry to the diag.
Well, I mean, the only thing that I would suggest, Marty, is that
We're going to take a safe wire, like a miracle.
if you put the IVUS catheter in the LAD, I think you can identify at least approximately where the entry to the diagonal is, based on that arc of calcium, and you see the diagonal coming in at like 12 to 1 o'clock.
So this is interesting. You pulled your wire back.
No, this is a before.
He's
No. Just looking at the old.
All right,
trying to find out the diagonal.
I got scared there.
He was reviewing the film before.
I got nervous.
No, that's...
Yeah, well, the fellow pulled the wire.
Okay. We're going back in time.
He's not even in the room.
Which diagonal are we obsessing about? The one before the lesion, or the?
You might want to look at the prior angiogram, the one from a year ago.
We're obsessing about the diagonal.
I think you'll have to declare the diagonal loss, put a stent in, and move on.
Give me.
People say that nobody ever dies from a diagonal. I mean, it's much less myocardium than the LAD.
Let's do a dual.
We actually looked at this in about 10,000 primary PCIs, and there actually were 4 deaths from acute diagonal primary PCIs.
So Greg,
so it's not totally true.
Greg, S.J. Park want to make a comment.
Yeah, actually, diagonal concern is there is already occluded arteries in terms of jeopardy, myocardium concern, clinical concern, have already ejection fraction lowers, and I don't too much deal about diagonal branch interventions. We save the LAD arteries. That would be enough to
I agree with you, SJ. I really do. I think sometimes as an interventionalist, we obsess about trying to make everything perfect.
It's another 100 cc of contrast. It's another half an hour of work.
Sometimes the diagonal may show up after you stent, so I would just not stent the LED and be done with it.
Sure.
And take your chances. No waste time here.
And if it doesn't go, we just.
I think
I
it's
think
not going to
if you
show
can
up
get,
here.
I think if you can get the diagonal relatively quickly,
it's
great. But I don't think we'd spend another hour on the diagonal.
And 100 cc of contrast.
This is one case in which
No,
I think...
no, what we're going to do, gentlemen, is we're going to go down with a microcatheter and then take a wire and see if we can get into the diag. We have roughly an idea what it might be. If it doesn't happen in 5 minutes, we stent the LED and we either fight it another day or we just let it be. Yeah. You know, sometimes the enemy of good is better. Yeah. And certainly I wouldn't go through epicardial collaterals in this gentleman, you know, just for this diagonal now. Just to give me a little...
And what wire would you take for the diagonal?
Just pro water.
For the sake of argument, this is
I'm
probably...
open to suggestions.
For the sake of argument, Dimitri, this is the one situation, or one of the situations, in which if you put the IVUS catheter in the LAD, you probably will have a better chance of localizing where the diagonal begins.
So pilot 50, fielder FC.
You mean try to wire it with the IVUS catheter there?
No, but at least
I'm just going to, Gary, I hear you. I'm just going to do a 5-minute, 3-minute with the wire, and then we'll put the IVUS, I promise.
We're timing you.
Miracle 3. And the idea is to see if you can...
Yeah, well, this right now is the pro order. This is a workhorse to get down
okay, so
and swap.
Yeah.
Do you see the wire, the catheter?
Not yet.
Don't touch the wire, just keep it back.
Coming now.
Where is it?
It's up top. It's coming down now.
Yeah, there you go.
Okay, I'll take a short one.
It's perfectly overlapped with the right guide.
So Dimitri, with your second wire, we'll credit you with a parallel wire technique here.
Kind of.
It's a modified parallel.
That's right.
Don't tell nobody.
It's a reverse parallel wire, where you've got it in the true lumen of the LED. Yeah.
So which wire did you pick?
It's always so hard. You get wire wrapping and bias and. This is the Pro Water?
Yeah.
Pro Water.
Okay, I'll take a Miracle 3, please. Yes, that was just to get there.
That's just to get down. So this is the Miracle 3 that he's going to shape through the short course there.
This is a technique we call "Do you feel lucky?" You know.
It's a scratch and run.
Anybody on the panel, any ideas to access that diagonal?
Yeah, just close your eyes and do the LED
I
stent
mean, if you want to get
and then
fancy,
see
we
what
could do a
happens.
selective injection, and we could look at the epicardial collateral, but I don't think the trade-off is worth the risk.
No, it's definitely not.
Stent the LED.
I mean, really, if you do convert him to an open
it's a way to
circ,
do it.
open circ, open right, open LED, and an occluded second diagonal, it's
and a great aortic valve.
And you fix the aortic valve.
You should live forever.
I think it's a great point, Greg.
Yeah.
I'm tired of that.
That could be it.
I do an
give it
injection,
Anti.
and maybe tip it in and get the XT. If we can get it, you know,
It's going to be very hard to see.
Ready?
Yeah. I mean, I like the direction. Pretty close.
It's a little bit of a fish.
It looked to me like there's a total occlusion of the diagonal itself, that it had occlusive
Yeah,
disease.
it is.
Well, there's plaque across the entrance.
Well, we created it,
Spencer.
I think you should put a stand and bring it as a
It's
total
not- it's
occlusion to
acute
the next
occlusion. It's
meeting.
not a chronic total occlusion.
You know, or you could use a 3-0 balloon and try to, again, really move the tissue planes even more.
Dimitri, your 3 minutes are up.
Well, we're not going to spend an eternity on this. Did you have an egg timer there, Spencer?
Yeah, I got the hourglass here. You know, it's dripping.
All right.
Well, Alan has the Apple Watch. He can tell us.
Okay. Give me the eye just for 2 minutes since we have some time on the transmission and see whether.
No, that's good. Yeah, we got 15. We got 15 minutes.
That's fine. I can.
I think we should bring this case to TCTAP 2016 for the diagonal.
For a CTO?
For diagonal CTO?
Yeah.
Diagonal CTO 2016.
All the major vessels open in New York, so we'll be down to the diagonals.
You know, from the retrograde injection, it wasn't that large a diagonal branch.
No.
Just getting smaller all the time.
We rationalize
It's
it.
disappeared now already, so.
But anyway, it's a
Yes, exactly.
More importantly, the dissection length is 25 millimeters, so we could take a 32 stent and we'll be happy.
Exiting the guy, D.
Yeah.
All right, so you're IVUSing again
So it's,
to really see where you want to land the stent?
Yeah, but we'll place it right, yeah.
No, we're just trying to, we're following Gary's suggestion to see if we can identify the ostium of the diagonal.
Honestly, I wasn't sure where. No, we'll do it mechanically.
Manually.
Just manual.
That's what I mean, manually. I meant
You can record.
Yeah, just record there.
you're coming
Just
back.
we'll put the, the transducer right where we think the diag is.
So it's coming right about
Yes, I'm coming
here.
back
It's
slowly.
right here.
That's probably where the diag is.
Right.
It's secluded, yeah.
Yeah, and you can see it's got
Okay, give me
solid
the...
tissue across the
All
origin
right,
of
all
it.
right, so now we'll poke at it.
Okay.
It's pretty
It's
close to
intimal
where
and
you
then
were.
basically
Find that out just so we have that.
Yeah.
Yeah, but I think you were subintimal there in the diag. We'll see.
But this
Give
could
me
be a
the,
good, Dimitri, this could be a good place for Confianza
Corsair,
Pro.
Corsair.
I mean, this is where you need something sharp and strong, I think, to get through that tissue.
Send the LED.
Yeah, new one. Numerical, please.
Give me the pro order just to get down there.
Is this the pro order here?
I think I might go up to a Miracle 6, Greg, but, Confianza for this diag, I think it's a little bit of a...
I've had too many epicardial stains.
Yeah, too many successes of a diag lately.
If you exit, not such a big deal. But you've got a lot of tissue to work your way through there.
Yeah, because you could always throw a geomet across, right?
I'm more worried about the distal wire dissection or end hole perforation than right at the crotch of the bifurcation.
True.
50% success if you don't go open up the diagonal. Is that cool?
You're there now, you see it?
I'll take a short of this. Yep.
You try 2 CTO in here. Yeah.
It's a question to Eberhard. How easy it would be to do this if it was a core valve? If there was a core valve instead of Edward, how easy was to get the 2 guiding catheters or guiding a diagnostic and to do this procedure?
I mean, I don't know in the specific case, but I think we've done this in the first 50 patients and we never had a problem. We know that if you're unlucky, then the strut is right in your way. So Sapien here is much better, I suppose.
But there is a specific guiding catheter that you would use through the core valve because you have...
I would not change anything. I mean, I would...
So, Gary, what do you think of this technique, doing it with the IVUS catheter there? I find it...
Well, it's a lot of hardware in a vessel that's not well dilated, but at least, I mean, my thought was not so much to leave the IVUS catheter in place, but at least
just
it gets
know where it is.
But because you can see that the entrance to the diagonal.
Yeah.
Yes, I'm just have it there until we have the...
You might consider, Dimitri, also, if you really want this diagonal, which I think
I tend to
most
leave
of
the
us are...
catheter there. When
But
I'm
it's
doing an IVUS guided entry.
But it's very hard. I mean, you've got to be very lucky to have the...
Plus it lets you push hard.
The
So
lumen
you
is
can see
behind
that the IVUS catheter is kind of against the origin of the diagonal.
And there's a lot of plaque sitting there, Greg.
It's a lot of plaque. There's dissection plane. There's calcium.
By the minute the wire's up.
You might think about a 3.0 balloon here also to give yourself more room to work.
You may want to crack
and
that
it may
plaque.
also thin out some of these tissue planes.
Where do we think it is now?
I don't see it on the iris.
Here.
Yeah, you can see it up around 1 o'clock, 2 o'clock.
I would go for up there.
Yep.
Yep.
Right around
Yeah.
there. Yeah, we're with you. Right around there. Maybe you can,
But the origin is not there.
But it almost looks like there's a tissue plane across the ostium of the diagonal. You almost have to go kind of around a 180-degree turn and to get.
Greg,
yeah.
Greg, you have to
confirm that?
I don't know. I've not been lucky. I've tried it, at least 10 times.
Good. We can confirm that. What do you think?
It's pointing right.
And the wire, make sure it doesn't get kicked.
It's pointing towards the lateral wall.
Can we see the iris?
Yeah. That's what you find, the diagonal in the lateral wall.
Yeah. We're just going to see it.
I think I'm just going to wedge
All
it
right.
there.
Okay. You going to tip it in?
Yeah. Give me a little. Let me just pull the iris back. I think it's too much to confirm with the iris
Okay.
now.
All right.
I have 2 minutes and 25 seconds.
It looks relatively okay.
A little bit into the roof.
Yeah, but it goes, the iris goes like, the vessel turns down like exactly how it goes.
What do you think, Gary?
At least in the architecture.
Looks pointing in the right direction?
Yeah.
I mean, at least it's favorable. 12 o'clock?
Yes, let's
do it.
Now it popped off.
And it's moving.
Oh.
And that's the end of the transmission.
No, we should have 10 more minutes.
Yeah. We lost transmission.
Maybe they blew out all the power in the cath lab. So when you're doing this, I'm sure they're working on getting this back. When you're doing this live, there's obviously a real desire to want to get complete revascularization. But I think we're all pretty much making the point. I don't know if it's going to affect this patient's prognosis at all to have that diagonal open.
Okay, we're back.
Hello, Dimitri, can you hear us?
Yes.
Good.
Yes.
Yeah. So
we lost you.
Can you see us get in and tip in the Corsair?
No, we didn't.
Well, it looks like the wire got into the architecture of the vessel. The Corsair is in now. Just give you the play-by-play. And now we're going with a pilot to see where it'll track in the vessel.
Okay.
So the Corsair is right at the ostium.
Right.
Yeah, we lost you for about 2-3 minutes.
Yes, just 2 millimeters in, Gary.
It's subintimal, but it's there.
So
it almost had to be subintimal.
That's the best
So
case
if
scenario.
you're going to take a Pilot 200 to see if you can re-enter?
I think you're making nice progress now.
Yes.
That looks like the right
I
one.
think it did.
Yeah.
No?
Either out or it's in.
Close in it. I don't know.
It's moving very freely.
It's
so
not. It's
moving.
It has the shape of the vessel.
I think it's in, guys.
Yeah.
Yep.
Yeah, I think
He's-
you're in.
You have a, yeah.
This is the one.
So now,
Yeah.
the question is, what are you going to do with the diagonal?
Okay.
It's pretty.
Yeah, you
Gonna
can
stent it?
Now what do you do?
It's just a
You
small diffusely diseased diagonal.
So what are you going to do with it?
Yeah, be careful what you ask for.
Now you resurrect it
Well,
to
we're
diagonal.
just gonna-
Well, you're going to try to keep it open. I mean, I think you're going to balloon it, and
Then we're going to take a bifurcated stent.
Give me a
yeah,
Putting
you're not
a Triton.
a Triton. Okay.
Triton.
So Gary, you were right. I think I gave us a little bit more confidence that we were where we thought we were.
We were actually there, but this just confirmed
Yes,
that
it gave
we
some
were
more
there.
confidence.
Yeah, that we could
There's
push.
nothing wrong with that.
But it was the pilot that made the entry, right?
But no matter what, you're not going to put a stent in this diagonal, are
I
you?
think so. I mean, if we.
But we'll see. This is a good demonstration of how the pro order
No.
will confirm or deny,
This is a BMW.
Yes.
or even a BMW.
Yeah.
No,
I think Spencer, the goal is not to stent this diagonal unless it gets much larger when you start dilating it. It kind of looks like a 2.0 right now, but maybe it'll plump up.
Right.
Get the 2.0.
This
Yeah,
diagonal,
this is not,
this LED diagonal system has been closed for years. millimeters too.
It's like a
So
30 millimeter
there's a
vessel.
lot of myogenic vasoconstriction. I don't know if you're pouring in nitrates or.
You think I'm in?
I think so.
But if you can keep the diagonal open, I mean, that to me is just the goal. You don't want to do anything to jeopardize the LAD stent.
I think it's just the osteum. The entry of the diagonal has to be preserved.
Well, we'll know with the.
I love these terms, Greg. Myogenic vasoconstriction.
That's an old term.
But what does it really mean?
It means the smooth muscle cells in the wall of the media are chronically vasoconstricted. And it sometimes will take them weeks to actually relax.
Well,
after
but
you
even
open up the
here,
CTO.
you're seeing the distal LAD plumping up very nicely, pretty quickly.
Yep.
But, you know, there are a couple of studies that have looked at what
a bunch
happens.
of studies, including Galassi's, that done systematic angios.
You know,
No, okay.
I mean, these vessels will grow over the next 6 months.
Yep.
The average is about a half a
No,
millimeter.
I think it feels like it's subintimal, guys.
All right.
Really?
Yeah.
It's not free.
Yeah, but that's at the end of the vessel. At the
Yeah,
beginning,
that's
I
right.
think.
That's not behaving right.
Yeah. The distal part is maybe.
Yeah.
How many do you want me to do it? Little star and get it open?
Yeah, I'd get the XT, don't you think? No?
You want to just start it?
Yeah. Don't you think?
Okay.
I would.
Okay, give me the filter XT, please. Yeah, this is subintimal.
Yeah, this is not, yeah. So we're going to see if we can pop into it with a little tiny knuckle.
So we've got about 5 minutes,
I
and
won't
then
do
I
a
think
thing
we're
here
going to go
for this.
to, then we'll go to Marty's lecture.
Okay, well, yeah, let's watch this maneuver and maybe a quick balloon, and then the rest will just be bifurcation stenting or single stents.
So tell us what you're doing,
I
Dimitri.
think there's certainly ample experience.
So you put like a 45
I just put a little umbrella on an XT wire.
45?
No, like a 180.
We're going for a knuckle.
Sure.
Yeah, we're going for an old-fashioned star here.
Yep.
But with an XT.
That looks.
Whoa! Well, that you never know.
Yeah, you know.
That went somewhere. Live.
Either intraluminal or really sub.
Yeah. But honestly, I've been there before. You can get fooled. Yeah.
Give me 363. So, Fluorostor, again, there's nothing elegant about this maneuver. It's the knuckle is not getting very big, so that's one thing that favors maybe that it has stayed into the lumen. Give me.
Yeah, medallion, please.
No, just whatever.
Yeah,
I
medallion.
just want to aspirate a little bit.
Yeah.
I'm not going to inject. I'm just going to aspirate back a little bit and see if I get any blood back. It's not a 100% reliable sign,
There is
but
blood.
but it's better than not having blood coming back. Okay, give me the BMW
Normal
back.
wire, please.
So you pushed that pretty fast, Dimitri. Did you?
Yes, I mean, who knows where we...
Did you intend, Dimitri,
thing
to
I
push
don't
it that fast?
Huh?
Did you intend to push it that fast? Was that you did?
Yes.
Okay.
Because the idea is that you knuckle a wire and the knuckle gets bigger fast in a transition that's a little bit stiffer. It finds a relatively healthy part of the vessel, so it pops into the true lumen from the subintimal space. So if you're going to do this maneuver, you have to do it that fast. Otherwise, it's not going to work. I'm not sure that it worked now, but at least this is the way I think it should be done.
This is a 50-50. You have the 2-0? You want to do a 2-0?
Yeah, 240.
Perfect.
Yeah, perfect.
Long 2-0.
I'll take a 12, please. This is the end of the vessel here.
Yeah.
So it's not just big diagonal.
How you
Yeah,
gonna
I
get
need a
that
trap, yeah.
We got this. We're going to have to get this
Yes.
up here first, probably before we can trap. It looks like it might be in, no?
Yeah.
We might be in a branch.
We're in it somewhere. The question is how distal we're in it.
Yeah. But we'll balloon it, and then we'll do a cine. Then if you have to go off camera, we can do it. Okay? okay?
You might watch that wire
Just give
tip.
us
That
like 2
wire
more
tip
minutes.
may be trapped in a capillary. It's not moving.
Yeah, I think that give me the
Please.
The knuckle was clearly in the main vessel. Now the BMW might have selected a smaller one. I don't know. I'm going to balloon and figure it out.
Remember that the main disease was in the ostium, so you don't have to worry so much about the distal vessel if you're not subintimal there.
Yeah, I got a feeling, Ron, that whole
Yes.
vessel was diseased. The occlusion was
I
in the
understand
ostium.
it's a hard out at 8:30.
Yeah.
So I'm going to take over
So-
and start my lecture.
Yeah, Marty,
I'm
why
going to
don't-
let you guys work in peace, and at the very end, we'll try to come back to you.
Perfect.
So you'll be able to
That's great,
take a look.
Marty.
Okay?
Perfect.
Thanks, Marty.
Great.
Thank you, everybody.
All right.
All right.
Have a great day.
See you next year.
Okay, Marty, we see you.
Okay.
Go ahead,
Well,
Marty.
again, I want to thank everybody for their kindness in inviting us to this incredible TCT Asia Pacific 20th anniversary. So I want to really say that this transmission is meant to celebrate a whole variety of things, but I want to certainly acknowledge our really wonderful long-standing friendship with S.J. Park and his terrific team at Asan Medical, and thank him again for allowing us to be part of this great meeting. I want to thank my special friend Eberhard Grube, who was kind enough to allow me to give this lecture because he's been one of my inspirations in terms of trying to move the valve field forward. But most importantly, I want to say that this whole transmission is dedicated to our very close and wonderful friend David Holmes, who's recovering at Mayo Clinic after surgery, and we wish David a rapid and complete recovery and hope that he's with us at TCT this year and at TCT Asia Pacific next year. So I'm going to address a difficult topic, and if there are any surgeons in the audience, they should fasten their seatbelts. Because the plan is to try to convince you that TAVR should replace surgery in almost all aortic stenosis patients. Let me begin by saying that my primary thesis is that this really is now the procedure of choice in almost every patient with severe aortic stenosis, regardless of risk status. But to accept this primary thesis requires two things. First, what I would call a suspension of belief. You have to uncouple yourself from the past, from being wedded to a concept that risk stratification should determine therapy. And second, that there already is a reasonable body of evidence demonstrating parity or superiority versus surgery from the standpoint of hard endpoints, mortality, strokes, quality of life, valve performance, and that there's also very measurable and important secondary benefits. So let's begin by going to my great friend, Alain Cribier. We've just passed the 13th anniversary of the first live case, and this is the patient that he did just almost 13 years ago, immediately after the procedure. This procedure was done without transesophageal echo. This procedure was done using a transeptal antegrade technique, and it was done without transesophageal echocardiography. As soon as Alain finished the case, he called and he said, okay, what now? He had proven that we could put a valve to treat aortic stenosis in a desperately ill patient, but it was completely unclear as to where this technology would go. I would say that with these two devices, the balloon expandable Edwards Life Sciences device and the self-expanding Medtronic core valve device, that over 125,000 patients have been treated through the end of 2014 and over 750 interventional centers around the world. If you look in the United States alone, you see the rapid progression from the entry of this technique in 2011, and right now there's about a 20% TAVR penetration estimated in 2014. If you compare the penetration of TAVR in the United States, it's similar to some of the countries in Europe, much, much less than half of what you see in terms of units per million population compared to Germany, much less than Switzerland, similar to France and the Netherlands. So we certainly have a long way to go. First, why don't we start with the guidelines? You're all familiar with the recent 2014 guidelines, which really focuses on risk stratification to determine therapy. dividing patients into low, intermediate, high, and prohibitive surgical risk, and then deciding that really the only class 1 indication is for TAVR in prohibitive risk patients, and there's a 2A indication for high surgical risk compared to a class 1 indication for surgery in high surgical risk patients. So these are the patients that we treat. They're very old, they're very frail, they have many, many comorbidities, and they look something like this. They're still enjoying life, but clearly this really is the end spectrum of high-risk patients with aortic stenosis. It's important to note that the body of evidence that's been accumulated over the past 7 years has been near remarkable. If we look just in the case of the PARTNER trial, almost 8,500 patients in FDA studies, including 4 randomized trials with 3 generations of devices in about 7 years. 4 manuscripts in the New England Journal of Medicine, recently 2 more manuscripts describing the 5-year outcomes in Lancet, and the results really are striking. If you look at the inoperable patient group, there is still more than a 20% benefit at 5 years compared to standard therapy, and only 1 patient in the standard therapy group was alive at 5 years who didn't cross over to either surgery or TAVR. If we shift to the high-risk group compared to surgery, you see these mortality curves are essentially superimposable, no difference. If we now move over to the more recent core valve trial, again presented in the New England Journal of Medicine, a high-risk group of patients. These are the 1-year and most recently the 2-year data presented at ACC showing not simply parity, but in fact superiority compared to surgery in high surgical risk patients with an STS score of about 7. So how do we shift to lower risk patients? Well, first, I can tell you that contemporary clinical practice has already evolved. In Europe and the US, risk strata are downshifting. There are multiple manuscripts indicating that, and if we look in the United States alone, from the very beginning of PARTNER to more recently the TVT registry, you can see an almost 50% reduction in STS scores in both inoperable and high-risk patients. So now if you draw an algorithm as to where we use TAVR, you can see that it's not just in the inoperable and high-risk patients. It's already beginning to bleed over into what we used to call intermediate-risk patients. Next, TAVR results have been better in low-risk patients, both early and late mortality. There are multiple studies that have been published largely in Europe, which clearly indicate that if you look at low versus high-risk patients, there's a dramatic difference in mortality. So in the lower-risk patients, the results are clearly getting better. Propensity-matched cohorts indicate parity with surgery in moderate-risk patients, and there are 2 randomized trials, one completed enrollment, and the next that's well on its way to completing enrollment. That's PARTNER 2A and SURTAVI. But in the 3 propensity-matched studies, you can see the Piazza, Observant, and Latib study, there is no difference in 30-day mortality between surgery and TAVR. Important TAVR procedure-related complications have been declining, which have already favorably impacted mortality. If we look at this meta-analysis from the Cleveland Clinic looking at strokes, there's been a striking decline in stroke risk with increased operator experience and with new technology. This is comparing the randomized PARTNER data with the later continued access PARTNER data, and if we examine vascular complications and bleeding complications, it's about 1/3 of what it was in the past. And if we look at patients that had complications versus no complications, there's also a dramatic difference in mortality. We also have data that TAVR bioprosthetic valve performance has been excellent with good durability, with no evidence of premature structural valve deterioration. These are 5-year data from the inoperable patients from PARTNER. These are the 5-year data from the high-risk patients compared to surgery, showing no evidence of early structural valve deterioration that required reintervention. And we have data up to 9 years from Vancouver, again showing no evidence of early structural valve deterioration. I would call it midterm durability, but certainly it's very encouraging. TAVR has had at least equivalent and often more favorable clinical outcomes versus surgery in multiple important clinical subgroups. We call these the TAVR-friendly subgroups, and they include women, diabetics, patients with small annuluses where there's less patient-prosthesis mismatch, the AS plus patients with either MR, concomitant coronary disease, or LV dysfunction, low-flow, low-gradient AS, certainly patients that have oxygen-dependent COPD, chronic kidney disease, frailty, extreme age, and either mild, moderate dementia or hepatic dysfunction. All of these patients are better with TAVR versus surgery. And importantly, TAVR in the modern era is less invasive with simplified procedures, and the next generation technologies have significantly improved clinical outcomes in both high and lower risk patients. So now the modern TAVR era is a minimalist approach with preferential percutaneous transfemoral access, reduced use of general anesthesia, less intraprocedural TE echo, the elimination or reduction of predilatation, decreased use of complex and costly hybrid cath lab and OR environments, and early discharge programs. This is the 3M strategy in Vancouver, which is multidisciplinary, multimodality, and minimalist with TF access and next-day discharge. There are many new TAVR technologies. I'm highlighting the Evolut R, and I want to show you some new data from the ACC looking at a randomized trial called the Notion trial comparing the self-expanding CoreValve Classic versus surgery in all comers. These are 2 centers from Denmark, 1 from Sweden. Yes, it's an underpowered study, only 280 randomized patients to either TAVR or surgery. Patient age was just under 80, 79 years, about an equal number of men and women. STS scores now are 2.9 and 3.1 respectively, and about half the patients had severe symptoms. And you can see the 12-month data on the composite index of all-cause mortality, stroke, and MI shown here. The log-rank p-value is 0.26, but certainly trended, in fact, towards superiority in this all-comers study with the CoreValve Classic. And if you look at secondary outcomes at 30 days, bleeding, cardiogenic shock, acute kidney injury, and atrial fibrillation, all markedly reduced compared to surgery. The only difference favoring surgery was a much higher frequency of the need for new pacemakers. And valve performance was in fact better, not even equal, but better than surgical valve performance. There are many other non-self-expanding valves, and now I want to highlight the SAPIEN 3 valve and some of the data from the ACC presented by Sushil Kadali, looking at the SAPIEN 3 valve in a large cohort of patients, 583 with high risk or inoperable status, and over 1,076 of intermediate risk patients. In the high-risk patients, the STS score was 8.6, the mean age was almost 83, and if you look at all-cause mortality and significant stroke rates, 2.2 and 0.9%. And now if we go to the intermediate risk, 1,076 patients at 51 sites, now the STS score is 5.3, the average age is just under 82, and the all-cause mortality at 30 days was 1.1, and the stroke rate, significant stroke rate, was 1.0. And this is core lab echo analysis of over 1,000 patients with a less than 4% significant PVL rate. These data are absolutely striking and cause us to want to change the paradigm. So we've already begun to check the low-risk boxes. It's already being done. Outcomes are better in low-risk patients. There's parity with or superiority to surgery, but we need more data in low-risk patients. But now Notion and S3I help. Complications are rapidly decreasing, including PVR. There's excellent valve performance and encouraging durability, midterm results, and procedures are becoming simplified with remarkable iterative technology evolution. So rather than saying that we should use TVR when patients do poorly with surgery, we need to change the conversation and say that we should do TAVR almost exclusively if the patient's a good candidate for TAVR. And who are those patients who do well with TAVR? Well, you've obviously got to have the disease, calcific aortic stenosis. You might want to avoid some bicuspid valves. You've got to have an acceptable aortic valve-R complex from the standpoint of annulus size, matched to valve size availability. Percutaneous femoral access is important. You want to avoid unfavorable anatomies, severe coronary disease, perhaps multivalve disease, extreme aortic pathologies. But frankly, we're talking about almost everyone with aortic stenosis. So I think you need to use the most recent guidelines to decide on the timing for intervention, but rely heavily on the multidisciplinary heart team for the choice of intervention, starting with, is this patient a good candidate for TAVR, independent of risk profiles, with careful informed consent, and finally convincing regulators that TAVR is not a niche therapy, but rather should be endorsed as a mainstream therapy. So where are we going with this? This was loaned to me by my colleague Philippe Genereux, and a few months ago, he did one of the earliest outpatient, same-day TAVR procedures. So if we had to go back to Alain Cribier now and ask him what's next, I think what Alain would say, and what I'm saying is now, TAVR for almost everyone. Thank you very much.
Thanks, Marty. That was really brilliant, very provocative. It seems like we're really just waiting for the long-term data and then reimbursement, but it seems inevitable. The train has left the tracks. Okay, Dimitri, we've got a few minutes here. Quickly, show us what's going on.
There we go.
Okay.
This is kind of the final shot. So we ballooned the diag. We knew it was going to be dissected at its origin, but you know it's a true lumen distally. We deployed the stent in the LAD. We have good flow. Just distal to the stent, you see preservation of septal, so that's an indirect sign that that's true lumen to true lumen. We will obviously IVUS and optimize the stent. But I think, you know, I would say that 90–95% of our goal was accomplished. We recanalized the LAD, single stent, we'll optimize it, and a patent diagonal.
It's not such a small diag, Greg.
Yeah, it's a moderate-sized diagonal.
It's all the way out to the obtuse marginal.
It's a moderate-sized diagonal. I think there's a good chance that that's going to heal and stay open. So I think it's great that you got it open, and I think the LAD looks beautiful. So I think you've really helped this patient. So congratulations, terrific case, everybody.
Thanks for all your help. Good to be with you.
Thank you so much.
Enjoy the meeting.
All right, fabulous. Okay, so we're going to go on to the next session, and SJ is going to welcome us to the 20th anniversary of TCT Asia Pacific. Thank you, everybody.
Okay, thank you very much. The next is opening of TCTAP 2015.